Ladies and gentlemen, thank you for joining us today for our series of health policy lectures. Today's health policy lecture is a dialogue with Dr. Marcelo Cork. He's an advisor for sustainability development and health security with the Pan American Health Organization. He is our guest this week at UTMB as we look at the potential for collaboration between our university here and with the Pan American Health Organization. We're really delighted that he agreed while he's here to do this health policy dialogue. As your host, I just want to thank you and thank those people that sponsor this event, the Office of the President, the American Medical Association and Texas Medical Association Student Organization, and also UTMB's Center for the Elimination of Health Disparities and Center for Global Health Education. We're pleased that all these people joined us in making today's event possible. Dr. Cork has been the regional advisor with PAHO since actually 1998. Currently, his responsibility is for developing the regional cooperative programs on health and human society for the Americas. And when we say the Americas, that's North and South, okay? So it's a vast territory. Previously, Dr. Cork provided policy and technical advice to senior government officials on environmental health, social determinants of health, violence prevention, human security, and healthy settings in the U.S. And U.S. border regions, such as Colombia, Peru, and Venezuela. So he's had a vast amount of experience in serving in those countries. He received his baccalaureate degree in chemical engineering from the Technikon Israel Institute of Technology in 1987 and went on to earn a PhD in chemical engineering from the University of Rochester in New York in 1992. He also has a master's in public health from the University of Texas, which he earned in 2011. He was a fellow with the American Association for the Advancement of Science in 1994 and received the Stanley Tyler Endowed Fellowship in Health Sciences in 2011. His topic today is the role of academic medical centers in attaining the United Nations 2030 Sustainable Development Agenda. Before we begin, I'd ask for you to please put your cell phones on silence, turn up your ears to listen to every word that Dr. Cork says, and be prepared to engage in a dialogue with him. Dr. Cork, thank you for joining us today.
That's great. Good. Yeah, thanks. Thank you very much. It's really a pleasure and an honor to be here. And I will say the opposite, since I've heard that it's a health policy dialogue and not lecture, let's make it a dialogue. I think that I would like that to go further than just a lecture. So please, let's have a conversation about what really the 2030 agenda is, what the university can do, what in particular UTMB can do about it, and how we can work together in the future for the Sustainable Development Agenda. So my first question is, who's familiar with the 2030 Agenda for Sustainable Development? Raise your hands. Okay, 3 hands. That's a good start. Okay, so please come on and give the, no, it's fine. So who's familiar with the Millennium Development Goals? The same 3 hands? 4 hands, that's good. Okay, so let's start. Maybe I'm going to forget all the presentation and we'll start with the Millennium Development Goals. That will make it easier in the dialogue. So let's start back to the year 2000. The year 2000 was really a key year for the United Nations, turn of the millennium, and it's the first time that 186 countries, they decided on a set of goals. Those goals were really 8 goals that it sounded that they were very simple to put together, but it was the first time in history of the United Nations that they put a quantitative numbers of what the countries have to do with regards to different subjects of development. For example, in health, the reduction of maternal mortality, the reduction of child mortality, infectious diseases, primarily tuberculosis, HIV/AIDS, malaria. And there were other components as well. For example, in education, gender equity, water and sanitation. So even though the indicators at the time, and we're not going to go over the indicators of what they were and the goals in particular what they were, but you can imagine, what they can be. They were very simple. Very, very simple. The key component of that was that it was the first time that 186 countries got together and decided on those quantitative goals and a commitment from those countries to move forward. And that brought obviously a lot of money for those countries. And then things moved forward, right? So let me show you some of the data that we have from the Millennium Development Goals. So in particular for health, as I say, child mortality, infectious diseases, water and sanitation, and then you also have poverty reduction, schooling, etc. Those that you have there, I don't know if you all can see, those were the 8 goals that we had in the Millennium Development Goals. And in particular for the Americas, we've seen great improvements for those particular indicators. But we still have seen that some of them, specifically maternal mortality, has been one of those that most countries could not accomplish. However, water and sanitation, the infrastructure of water and sanitation was really fine, even child mortality. And you have to understand that many of those indicators and goals, where they were defined, it was a little tricky because they were, defining with a 1990 baseline, not with a 2000 baseline. So the reductions that they had to have, or improvements that they have to have, they were not as good as it was expected because they were using as baseline 1990 and not the year 2000. But even though we really seen improvements on most of the issues. Now, what was the main concern from the Millennium Development Goals? The ones that they know about that, you know what they were?
Equity.
Equity. What else? And why equity? Let's put it that way. Not what else, but why equity?
Because the goals requested countries to report on country average.
Yep.
And didn't request them to report on the disparities within the country. Also, it didn't account for disparities among nations.
Right. And what else? What's the other characteristic of Millennium Development Goals? That was primarily done for the poor countries. So it was really, even though it was a commitment from all countries, it was really done for the poor countries. Because if you can see most of the goals and most of the indicators, they were really about diseases or issues in development that they happened primarily in the developing world, but not in all countries. So when we came with the issues of what are the drivers for the Agenda 2030, one of the main issues had to do exactly what has changed and what we need to change in order to have really a global agenda. Right? And that's where the issues of the 2030 Agenda for Sustainable Development, they come. And really, we did, passing from 8 goals to 17 goals. From about 30 targets to 169 targets. From about 80 indicators to about 400 indicators. So you can imagine that things got a little complex here. Just a bit. And even though you say, well, the indicators are so simple, we can really do it. Can you imagine if you have 196 people with 196 different agendas, with 196 different ways of looking at the world in one room, and that's just about countries. Then you have 500 civic society organizations. And then you have the humongous bureaucracy that we are, the UN system, because I don't know if you are aware how big the UN system is. Everybody talks about the UN like it's one building in New York. But the UN is not one building in New York. As a matter of fact, the other day they were looking because, you know, when we look at our pension funds, we were looking how many people work there for contributing, right? So we were looking and said, how many people really work in the UN? You know how many people work in the UN? How many people you think that they work in the UN? The whole system. Okay, you know how many? You know? Well, we are 150,000 professionals, technical workers technical and politicians that they work in the system, plus 300,000 people in the countries. So it's about 500,000 people that they work in the system. You know how many agencies the UN has? That building in New York? Beautiful building. You know how many agencies have? You know? Over 30 agencies. Okay? So there are agencies probably that you have not even heard that they exist. Agencies about aviation, that they control the world aviation to understand that they all is standardized of the whole world. They have WHO, which is an agency. They have UNEP. You have UNEP for environment. Then you have UNDP for development. Then we have UNESCO for education. Then we have for refugees. And then we have for migrants. And then we have for this. And then we have for that. And then we have UNAIDS. And then we have whatever you want to have. Tell me one. I'm sure we have it. Definitely we have it. So imagine the way that this agenda was built, different from the Millennium Development Goals, is that they did it in 3 parts. One part was what the countries think. So you have 186 countries, 195 countries, together coming to define goals. Then they say, let's ask the civic society what they think. So they put together the international organizations, just like Oxfam, for example, for children and all the others for refugees, and they have to come and they see, what do you think that the goals and indicators should be? And then they put us, the over 30 agencies, and come up with the same questions. And then when we come up with all these 3 components, put all that together in one salad, put a little bit of vinegar, put a little salt, and you get a mess. And that's exactly what we had. And it took years of preparation to come up with what is now the Sustainable Development Goals. Because to come up with the definition of each target that has the words that all countries accept, that the civic organizations accept, and that we as technical component of the UN say that is acceptable, we say that we agree, it is like United States with 50 states on steroids. You know, I mean, it's like they put you on steroids, and then we get those discussions with 185 different cultures from the countries. So it really is an incredible, incredible piece of work to try to come up with that. So because we couldn't say that everybody will achieve the 169 targets, we call this politically correct word is that this is an aspirational agenda. I don't know what you're laughing at. Tell me what you're laughing at.
Aspirational.
Yeah, so what's aspirational for you?
Striving to get there, but you're probably not going to get there.
Yeah? You're too blunt. I mean, definitely you don't work in the UN. I mean, you will not get too far. So, if it is an aspirational agenda, and we have 17 targets, and we say that it's all about equity, like Kenny said, it's all really about equity. What does that really mean to you? What does it mean? If it's aspirational, we came to all this exercise, so why is it important? Why do you think it's important? Say whatever you want. There's no politically correct answer. I'm not the politically correct type. They know already I'm not the politically correct type. I've heard all, so don't worry. Why? Why is it important? Why saying that it's about people, about the planet, about the partnership, about peace, about prosperity? 17 goals, 169, everybody together, one brouhaha, let's party together, but it's aspirational. So why is it important?
Because if you don't have any goals, you're not going to have anything. You have an aspirational goal that needs to be that's forward focus.
Excellent. What else? It's a good start. What else? Yes?
Clearly, to make the world a better place, you have to have a goal and an agenda set out. And it's a great plan, again, to make the world a better place, to be an agent for change.
Yeah. What else? Yeah.
If you don't plan with the people that you're planning for, if they're not involved in the process, it's not a plan.
Correct.
Well, aspiration is a desire. And if you don't have a desire for something, you're not going to have the motivation or the will to work towards it.
Beautiful. And that word desire is huge. That goes together also what you're saying, and they all are saying to a certain extent, because the fact that it's a world agenda, the fact that it's not just the big rich countries saying to the poor little countries, this is what you need to accomplish, but it is a desire for everybody to move forward. Some of them, they will choose to move forward more on maternal mortality. Some of them, they will have to move forward on climate change. And some of them, they will have to move forward on road safety. And the fact it's a big enough menu that there is something for everybody. Not only that there is a big enough menu that there is something for everybody, but very smart, what they did, very smartly done, is that there is a lot of repetitions in the goals, in the targets. Why? Because it's a way to break silos. And I'm sure you have no idea what a silo is, right? There are no silos in universities. I mean, they all work in a nice team, multidisciplinary, intersectorial. Nobody fights for their own budget, right? I mean, everybody shares budgets, right? Sure, yeah. They share knowledge, right? Everybody shares their knowledge. They share their monies. They share everything, and we all work together. Well, what you see in a university is the same thing that happens in a government. Governments work like that. And the way that they try to solve that to a certain extent is saying, listen, for example, violence and violence prevention is not going to be just on health on violence against women. Let's say when gender equity on violence against women, we're also going to put it in cities that they are safe and secure. So we're going to put something very similar here and there, so the people that then they will consider accomplishing and getting to that desire and goals that they were mentioned before, that they have to do with safe cities, will have to work with the people from gender equity, because it is the same indicator and the same target somewhere else. Road safety, it's in safe cities, but it's also in health. So it sounds very simple again, but acting with that, I tell you exactly an example from our organization. The day after the 2030 agenda was adopted by the countries in September 2015, okay? And it was said that this is an agenda that has to be not about goals, and that we shouldn't, as WHO, Pan American Health Organization is no more than the American Regional Office for the Americas of the World Health Organization, but we have two hats, and I will tell you a little bit about that. We said, don't consider that health is only the Sustainable Development Goal 3, which is called health, right? It says there, health, how do you call it? Health and well-being, right? So that's a Sustainable Goal 3, 13 targets, all in health, maternal mortality, child mortality, road safety, chronic diseases, non-chronic diseases, infectious diseases, environmental contamination, chemical safety. Pretty much it's like you put the whole plan of WHO in one target, they put it there, everything, and then they say, but don't consider only that. The day after that happened comes our director and says, okay, now we need to work on Goal 3. Exactly the day after, he already tells the director, we have to go work on Goal 3. And the system overall and the countries overall, they know that, because that's what we're paid for, to be silos. So we have silos in government, we have silos in the UN, we have silos everywhere, because that's what is our level of comfort. So it's how do we learn to break the silos? And we all talk that multidisciplinary, intersectorial is fabulous, but it's not that simple. For example, let's talk in government that says we need to do an intersectorial project. No, in health, road safety, violence, take whatever you want. Violence, let's take violence, youth violence, with the criminal justice system, right? So we need to meet health with the criminal justice system, right? And they need to work together. And this is not the US. Let's say that this is country X. Let's not put a particular country. It's a poor country that barely has resources to pay for their employees in the government, right? Barely for that. And they tell them now that they have to work together. They don't tell them how to go together. They say, we would like you to work together. What's the first thing that's going to come up? What? Who's in charge? And what's the second thing that comes with that? Exactly. Who pays for it? Who pays for intersectoriality? What is the sector of intersectoriality? I mean, it's like what I am, the agency of the intersectors. I'm the glue. You know, so you have the Environmental Protection Agency, you have Health and Human Services, you have Agriculture, you have Department of Defense, they have all that, and I am the Department of the glue. That I put everybody together with my budget, and which Congress will give budget for that? None. Not here, not nowhere. The only difference here is that the departments usually have money. Somebody has leadership, they can really sort of move the resources around, or if there's a presidential leadership, they can move those things forward, which happens in other countries as well. So that's really where all the complications come. We don't think about those things, but it's permanent. So we filled our mouth in the UN about saying, okay, we have to work among sectors. But the truth is that, why? I don't get the benefit. I don't have the money. Who's going to be in charge? It's going to be you. Why you? Why criminal justice over health have to be in charge? Who makes the decisions? Why making that decision? And those are very important things for get things done. And then the other thing is, in this agenda, which is different than the previous agenda, is that the previous agenda, they told them in the Millennium Development Goals is that because this is for the poor countries, we, the rich countries, we're going to pay for it. We're going to pay you through different vehicles, USAID, Global Fund, you name it. We're going to pay for it. But now it's an agenda for everybody. So now who pays for it? Who pays for it? It's not a cheap agenda. Let me tell you, it's really not cheap. Who's going to affect what? Sorry.
How it's going to affect the people above, how it's going to take away from their budget.
Okay, but who's really going to pay for all this? You know? What? Yeah. From where? Maybe. So the question, which is very good, I mean, it's true. What they're saying now is that, wait a minute, now it's not USAID or the Global Fund or the Bill and Melinda Gates Foundation just giving money. Now it's the country that has to come up with a plan that can really, with that desire, but with a plan forward to say how they're going to move towards these goals. And select the goals that you think that you have to move forward and move forward. So who's going to really observe that that is taking place? You see all the issues that they come out for an agenda that's so complex? How do we know the question and the issue that you raised of equity, which is the center of the agenda? And what is equity? Do you know what equity is? How many of you have used that on a regular basis? Equity, the word equity. Oh, that's good. You're getting better there. So what is equity? I mean, you already said it before, but let's go back because that's the center of the whole agenda. What is equity? Go ahead.
Well, health equity, when we talk about health inequities, the opposite, we're talking about differences in population health that are unnecessary, avoidable, and considered unfair. And so equity is not just differences in numbers and rates, but there's a social justice dimension to the definition. It's fairness.
It's about fairness, right? That's a bottom line, like you said. It is about fairness. So just give me, you're all in certain professions in health, right? Either as students or as professionals. Give me examples that you think that things are unfair. What is unfair in the health sector? Whatever that is. Yeah. Both of you, yeah. Yes, go ahead. What, sorry? Food insecurity and... Sure. Yeah. Yeah. No, he brought up equity.
And I look at social equity as an ideology still strongly held in the academic community.
Okay.
It has not bled into the real community.
Yeah.
So how do you even get groups to the table to discuss an ideology that's not even necessarily acknowledged by it?
A beautiful question. And I definitely would like to answer that now. Let's answer that before we go to the equity. And where are you from?
Here.
What means here?
Oh, Dallas.
Ah, okay. So you're from Texas, originally from Dallas, right? So let me tell you one thing, political, really political. The U.S. has not, in particular the U.S., the concept, at the policy level I'm talking about, right? Not at the academic level. That's to tell you about, has not considered equity during the past 15 years that has been around. For obvious reasons that we don't have to go over them. I think that we are all good enough to understand and we have enough knowledge. So even when you go to the CDC site or whatever at the time, they will say this is about health disparities, right? And everybody understood what health disparities were. Even here it's called the Institute of Health Disparities, right? And what's the difference with just health disparity and health equity?
Well, in my opinion,
Yeah.
the way that I think that we projected health disparity is that it's not fair and it's a difference in how we access and receive. But health disparity almost suggests that the people affected had something to do with that.
Mm-hmm.
Versus, to me, inequity is suggesting a systemic issue. They never had the chance
Correct.
to make that access.
And the reason of that difference that you're mentioning, and health disparities a lot has to do with just differences. Okay, so it's like it's very open. You don't know if those differences are because of the systemic issue, or those differences are just because genetically we are different, or those differences are because of individual factors in the ecological model. You don't really know where you stand. You don't know if you stand in the policy components of that, or you stand in the individual component of that, correct?
Correct.
Okay. When you go to health equity, or what you say, the inequity, then you are putting a statement that it is about systematic, that it is about policy, that it is about programs, that it is about plans, that it's not about the individual, but it's about where the individual lives, right?
Yeah.
And that's exactly where we, in the United States, we made that step now. But in other countries, they have been making that for a long time.
But wouldn't you even say that a lot of times we mischaracterize equity with access because we create...
You mean access to health services?
Well, because we create the programs, we create the infrastructure, but we didn't engage the people we created it for, and we don't really do anything to make sure that those people that couldn't access it now are accessing. So it's almost like those that were privileged to access now have greater access.
Yeah, but that's just a very small example in the big picture of equity. And I give you another example within the health service that it's not about the infrastructure, the health service infrastructure. But let's say that, and we did a study, a health impact assessment, for example, in Doña Ana County, New Mexico, okay? And the main issue for their access was a biased, which is what you were saying, an unfair program on public transportation from the poorest communities to then have access not only to health services, but also to better food. Yes. I mean, to supermarkets. Okay? So we are talking here about just purely talking with the public transportation system, not even within the health sector. And one thing that the health sector is horrible worldwide is about talking the other people's language. We are fantastic about talking our own language. We are highly technical, even if you're in the medical field, if you're in the public health field, if you're in any field in health, you know your language. But go and talk to a person in housing, in the housing language, and saying what that housing plan and why that housing policy is unfair. Why that transportation policy? Why is unfair? Even within the health sector, some things that they are unfair. You see how it gets even in the, and I try to bring it to the health sector, but that's what we see all the time.
Yeah, because public transit, is health. Or all, you have people who spend, significant percentages of their day, on public transit.
I give you an example I gave to the colleagues before in Hudspeth County that we talked before. The people, they were illegal, well, not illegal, they were just farm workers in Hudspeth County, Texas, that they could not go from Fort Hancock to Sierra Blanca, which is the capital of the county, where they really have the clinic, which is about 10 miles, because if they did not have papers, they on purpose, the county judge put the clinic there, so they have to go through the border patrol that it's on I-10. So they had to go 60 miles to El Paso, Texas, to get health services. Okay? This is Texas. This is not Ecuador. This is not Bolivia. I'm talking about Texas. So telling about unfairness in the systems, okay, that it's very subtle. Very subtle. And sometimes it's much more subtle than that. That's not even subtle. That's obvious. But you have to point it out. And those are the kind of programs that we say it's about unfair. Right? So that's exactly, you wanted to say something about equity as well, right?
I think you were looking for examples
Yes.
in equity.
Yes.
And so my example connected to what I work on is environmental injustice.
Okay.
Given that people that do not have wealth live in places where they're much more exposed to toxic chemicals and things that we discussed.
Right. And then we enter in problems because it's not so much in the States, although it happens a lot, but in other countries, which is even worse, it's like about informal settlements. So people, they start to live in informal settlements, that they're highly contaminated. The problem is that they live first, who is the first, the chicken or the egg? Who moved first there, the contamination or the people where they can live? And then all of a sudden, you have thousands of people that live in informal settlements, but they tell you, yes, but you should not supposed to live there. But then they tell you, yes, but I don't have any other place to live. And yes, but this area contaminated, so you shouldn't, that's an area. So you see what I'm saying? There is a whole chicken and the egg type of thing that you cannot really break in some situations. And that's why I end up having all these issues with these urban areas that they're so informal. And that, like it or not, people, they will live there forever. And they will have first, second, and third generations will be living in the favelas of Rio, in the shanty towns of Lima, and for the ones I know, and that's the way they're going to live. And that's part of all the environmental issues that they go with you. Who receives, for example, one big question in Texas again, that when I was living in El Paso was a big question, is how water. Water is not a right. In the United States, water is not a right. We agree with that? No, we don't agree, or no, it's not a right?
It's not a universal right.
That's right. So it's not a human right.
But people have rights to water in Texas.
Okay, tell me the rights to water in Texas.
The rights to water are basically contractual, which have been established over many years. Some which date back to
Beautiful. Right. Tell me that contractual agreement now in the colonias in Lower Rio Grande Valley.
So the people in the colonias have no access to water because they don't have the right to have that water because that right is signed away someone else 500 years ago.
That's right. Therefore,
Therefore, it's not a universal right.
it's not a universal right, but we are looking about universal rights. I mean, the human right is like, in a way, a universal right.
Yeah.
And in the end, it ends up being a commodity. Right? It gets transformed in a commodity. Okay? So water is a commodity. So in El Paso County, for example, again, I go back to the areas that they have the experience that we have studied, that lives 800,000 people. You have 13 water districts, which means 13 water politics, 13 water fairs, 13 water prices, and guess which water is the most expensive? Because it's a commodity. So which water is the most expensive? Huh? No. No, for the poorest. That's right. For the poorest people end up being, you know how much, if you don't get water in a colonia in El Paso County, Texas, they charge for a tank to take you 50 gallons of water? Yep. That's interest. Okay? So it charges you $50. You know how much of their salary a minimum wage person, that most of them are minimum wage people, let's say they earn about $1,000, $1,200 a month, they pay on water every month in a colonia in El Paso County, Texas? In a colonia with no water, that they have to bring it with tanks. How much do you think that they spend in water? In between the water they use for cleaning, for drinking, you know? Or because the water that you get from the tanks you don't drink. You use primarily for cleaning, and it has residual chlorine, so they don't like it, they prefer to drink water that it's bottled water, blah, blah, blah. How much you spend? Bless you. Well, it is 20 to 25% of their salary. How many of you spend 20 to 25% of your salary on water? Now, tell me if that's not an inequity. Tell me if that's not an inequity. You know the numbers, what they say about the use of water, how much we should pay on water per month? About maximum 3 to 4% of our income. Max. And these people pay 15 to 25% of their income. And not of the best water. Another example of equity that you want to discuss that comes to your mind? Any? There are tons. Come on. Okay. Tell me about education. That's a beautiful one. I love that one. So what about education?
You have some schools that have beautiful libraries and the best teachers, small class sizes, and you have other schools in maybe not so nice neighborhoods that have no library, maybe big classes, not very good teachers.
And why is that? Because you told me the fact, right? Yeah. But let's go back one step back. Why? 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 Good. And I love you. Exactly. How is the property taxes in many of the countries really, what do they do? I tell you now what I know about Fairfax County, Virginia. That's where I live now, okay? Fairfax County, Virginia. You live in the wealthy side of the county, you have the best schools. You live in the worst side, in the more poor side of the county, what do you have? The worst schools. Why? Because it's a property tax base. So we, the rich people of Fairfax County, we pay much more in property taxes. We get schools. Shouldn't be a policy that they should be a reverse distribution of the funds to make it more equitable and ask for the best teachers instead of being in the wealthy area schools to the best teachers to be in the areas that it's more needed and pay them very well. You know what they did in Medellin, Colombia, the mayor there? Something, what really was the main issue that cut the violence there. What was, you know? He said, I'm going to put the best public facilities in the worst areas of Medellin. And I'm going to connect all the city, no matter what, with metro. So the rich and the poor will meet in the metro, and they will take care of the public transportation system, and the libraries and the parks and the basketball courts and that, they will be envy of the best areas of Medellin. And that's what they did. And they had the best teachers in the worst neighborhoods. And they had 24-hour open libraries with the best computers in the worst neighborhoods. And that created a difference in Medellin. Medellin in the 1990s was one of the most, has the highest per capita, incidence of homicides. The homicides in Medellin were known to be the most violent city, one of the most violent cities in the world. And it took leadership, it took vision, it took leadership, it took guts, to really try to do it in that way. 10 years. But nowadays, Medellin is a thriving town. With its problems, yes, because they're not solved, but at least you are not that type of city as it was before. But that takes a whole different way of doing things, and it's not business as usual, because business as usual will give you the same results. Okay? So if we go back to this a little bit, it's saying how, I told you about this before, how one thing connects with the other. So for example, health on the target 3 connects with the 1 that it's no poverty, and connects with the 16, and connects with the 6 and 2. It doesn't matter. It's just examples so you get the idea of how we have to be interconnected and how we work in an interconnected way. From our perspective, and let me tell you, I don't know what's the time now? Because, oh, great. So let me tell you a little bit about Pan American Health Organization. Who do you know? What do you know about us? That's the best way to say it. What do you know about us? What's WHO? What's the World Health Organization? Besides doing bureaucracy, which we do very well. What else do we do? Oh, I wish. That would be fun. What else do we do? Sorry, what else? What do we do as an organization? What do we exist in the first place? Convener. That's one of our main jobs. That's exactly we are mediators in a way to understand differences between countries, positions, and health in this particular. The Pan American Health Organization, we have 2 hats. We are the American Regional Office of the World Health Organization. Yes, since 1948. That's when WHO was created. But we are also the Pan American Sanitary Bureau, which was created in 1902. And we are part of the Organization of American States. So we really have 2 hats that for many of you, I don't know why it's moving, it doesn't matter. It's like for many of you, it may sound like, well, what does that mean to have 2 hats? But in the policy world, in the convener world, I give you one example that will change in the coming years, but until now was a major thing. The Organization of American States did not allow to have Cuba as a member, where the UN had Cuba as a member. So for example, if we have the head of the Organization of American States, the Special Agency for Health of the Americas, for the Organization of American States, we could not name Cuba, we cannot negotiate with Cuba. On the other hand, when we put the head of the UN agenda, then we negotiate with Cuba, we talk with Cuba, and we have to separate the line very well. Which agenda is which? And which policies are which? Okay? That's just to give you an example of the differences between one. And why the Pan American Health Organization was created? Why WHO was created? Why? Yeah. We were created because of the Panama Canal. They really was a protection issue. They had to protect the engineers that they were going to build the Panama Canal in order not to have yellow fever, but the U.S. did not really have good relationships in Latin America, so they needed an intermediate body to really have to develop that relationship. So let's create an organization that will develop that facilitate, convene the parts so we can do that. And we had a U.S. director until the 1960s, which was the U.S. Surgeon General until the 1960s, was really the director of the Pan American Health Organization. And then we started to have directors that they are not from the United States. But the deputy director always have to be from the United States. That's really the way we are set up. So you can see that the United States has quite a say, which as a matter of fact, from our regular budget, about half of our permanent regular budget comes from the United States. But their permanent regular budget is about 50% of the total budget. So we have 50% is dues from the countries that they pay a quota to be part of the organization. We receive about 5 to 10% from the World Health Organization, and 40% we compete with universities for Bill and Melinda Gates Foundation money. So let's compete together, right? I mean, so we know, but we have more, it's what we call voluntary contributions from the countries and from foundations. We tend not to apply for competitive grants. That's not really our role. Well, we get voluntary contributions from countries. So that's what we do. So really what we do is we convene. We do write and we do studies. We really convene the best minds that exist in the field. Usually in the Americas, we try to convene the best minds from all the Americas. Especially, let's take the case of infectious diseases now with Zika. It's not that we're going to take just the CDC to do it and that's it. It's like we're going to bring Brazil and Colombia, and we're going to bring Central America, and we're going to bring the different point of views. We put it in one room and come with a decision, and we'll try to facilitate that process. So it's not that we do it ourselves, but we need to try to convene that process, and that process is fair, and that everybody has a place to say, and it's not that's a position. And I give you an example of that. How many of you are familiar with the National Health Security Agenda? Okay, tell me about it. Oh, okay. Tell me anyway. Okay, so there is a National Health Security Agenda, okay, which has to do a lot with infectious diseases, obviously, health emergencies, okay, and there is a Global Health Security Agenda. So there is one big difference between the National Health Security Agenda, the U.S. National Health Security Agenda, and the Global Health Security Agenda. Okay? Usually that tells you exactly the kind of things when things are sometimes not convened, mediated in the best way. And we saw those results in the Ebola in Africa. Why? Because from the U.S. point of view, or from a rich country point of view, to be more generic, okay, which is fine, they said our interest is the epidemiological intelligence to get what's going to happen. We see if that's going to come to us in the future. We need to understand. We need to get the information. We agree to that, right? What is missing is Chapter 1 of the National Health Security Agenda in the Global Health Security Agenda, which is about community resilience. So what happened is that these poor countries that they do not have more than bare bones capacity for surveillance, and they are running around for the interest of the people that they give them money, many times they are not working on something that happened in the Ebola that caused a lot of violent conflicts in those communities. Why? Because many non-cultural competitive issues, I mean, the competence, the cultural competence in which it was acted in the issue of Ebola in Africa was absolutely horrible. Horrible. Okay? And we all know that. We all try to go against culture. We all try to go against the fact that if a person really is dying of hunger and he sees a dead monkey in the floor, he will try to go and eat it. Okay? They don't care and ask if that dead monkey is sick or is not sick. They will do what they can in order to live. And that's what they have been doing for years. The way that they treat the dead people, they have been doing that for 300, 400, 500, 600 years. So just saying, don't do it, it's not going to cut it. So what did not work at all is that we did not work on trying to work with the community on how their beliefs, their health beliefs, and their beliefs are. And we were saying, okay, let's put these people in quarantine, and we acted like a typical epidemiological case, which it didn't work. And we know that it didn't work. Okay? So that's an example of how we need to interact the different parts of health. It's not enough to get surveillance. It's not enough to act in quarantine. It's not enough to that. We have to understand the culture. We need to understand the rules. We need to understand the beliefs. We need to understand where their health systems are. We need to understand why they do what they do and why they don't do what they don't do. And that comes also, if we're going to go and make a world, and that's where we're going now, and this is trying to cut it, but it's not doing such a good job already, is trying to cut the fact of dealing with health as if we are in a permanent health emergency. Okay? Which is a very medicalized way of looking at health. And I'm sorry for all the medical doctors. I come from a medical doctor family, so I already agree to disagree. But looking at public health from a medical manner only, I'm not saying not, but only, we're going to go from health emergency to health emergency to health emergency. So we're going to go from short term to short term to short term to short term. And who's going to deal with development? And development is not pretty. And when they ask me, well, how long is going to take this agenda to take? I tell you how it's going to take. It's going to take, at least if we work well, 2 generations. It's not a 5-year, it's not a 15-year, it's not a 30-year. It is probably a 50-year agenda. If we do it well. Okay? So it's not only the money, it's the resources, it's the way we look at the world. We try to change the way we look at the world, but it's not easy. And now the world is taking us more towards doing the politics, is taking us more about dealing with health emergencies. And even in the development agenda, we are really doing with some things that are very, very hard, which there is big disagreements in the system. Big disagreements in the system. Among them is, how do we deal with the private industry? The question is, how we should deal with the private industry in this agenda? Tell me. What do you think? It's one of the biggest issues. How do we deal with the private industry?
You mean for this kind of a goal?
Yep.
So you'd be asking the private industry to pay for it?
No. I'm asking you. What do you think? I'm not asking the private industry to pay for it. No. But what's the role of the private industry? I give you an example. Zika. Right. Comes Glaxo and tells me, we're going to donate a research lab, and no gain, no lose money for us, but we're going to put all the resources to develop a vaccine for Zika. What does that mean for the global health community? That's the question. What does that really mean for the global health community? What does it mean for the global health community that the Bill and Melinda Gates Foundation will try to finance a particular vaccine for malaria? What does that mean?
Are they going to target specific areas of the...
What do you mean by areas? Like geographical areas?
Geographical areas. When you say global, I'm thinking on levels of everyone.
Yeah.
So when you say private sectors, or I'm looking at just targeted areas.
For example, I mean, like the Bill and Melinda Gates Foundation, they will target Africa to have a vaccine for malaria, for example. That's what you're saying? Okay, but what does that mean? What does that mean for the world governance, for global governance in health? That's the question. If I am Bill and Melinda Gates Foundation. I am the CEO of the Bill and Melinda Gates Foundation. I have, how many, $40 billion foundation, give or take 10 billion? That's okay. And I say I'm going to give $5 billion, okay? That's what I'm saying. I have $5 billion to develop a vaccine, an anti-malaria vaccine. $5 billion. The budget of the World Health Organization is $5 billion. Okay? And Bill and Melinda Gates Foundation tells you that. What does that mean for world health, global health governance? Who gives the priorities?
Assume that trying
whichever country or even of the country agendas. So the ways in which the desire of those people, communities, countries, even regions sometimes are represented or not represented, translated into fundable programs or not, it's a question. So it means that the Gates Foundation in this scenario has decided to allocate $5 billion, which may or may not be consistent, and you don't know how what they've listened to and how they've determined that that's where they're going to spend the money.
That's right. So what we're going now, and that's, I leave it up to you and the last minutes that we have to think about, is in the current world that we are really push for these partnerships, public-private partnerships, and that we have the global governance in health. And we are dealing with issues that they are big money items. Big money items. We are talking here with the biggest pharmaceuticals in the world. We are dealing here with the biggest foundations in the world. Who makes the decision for whom? And that's the question. Who makes the decision for whom? Yeah.
And it's not only the private sector. Actually, for WHO, 80% of the funding is allocated, earmarked to certain activities. So this means that the whole governance of WHO to
that's the global governance
priorities and to have resolutions is filtered by the modes of funding.
Absolutely.
So, yeah, we can have 20 resolutions out of WHO, but 5 of them are going to be implemented because the big powers decided that the money will go here. And this is a big challenge for the Sustainable Development Goals, which there is a huge fear that these goals are going to be filtered by the will of donors.
Yeah.
Regardless who are the donors. They can be countries, they can be private.
Is the position what money, the power that money brings. However, ends up that now private sector in all levels is the one that, for obvious reasons, especially in regions of Africa and some in part of Latin America, they are really trying to open new markets and have for new products for development. And that brings a big issue of the global governance. Who makes the decision within WHO? Yeah.
Globally and in international relations. And, you know, I've been brainwashed as a realist. and so my view is that international politics is a state of anarchy.
Absolutely.
You have competing states who have different views on things. You have non-nation-state actors whose interests are maximizing profits. And so what you get is just, result of people with different positions of power and authority making decisions. There may be some kind of theater around it that enables, certain voices to arise, but nevertheless, it's about power.
It's only about power. Okay. And I'm a realist too, so I totally share with you the point of view. It's only about power. The only difference is that the difference between WHO in general is that at least we still have countries that they try to fight that particular situation, where in other regions, like in Afro, they fight much less because they are much weaker as from the global governance level. So it's how much they will be able to fight to create that scenario. It's going to be the question in the coming years to see what the directions it will take.
Thank you, Dr. Cork. I'm sorry, we're going to have to draw it to a close. It's been a great discussion. I'm sure you'll be here for a few minutes after.
Oh, we're going to be here. I don't know.
Can we please show our appreciation to Dr. Cork? Thank you very much.